Hi, my name is Katie Connor. I've been working in PA education for about 10 years. I'm also an orthopedic surgery PA in Charleston, South Carolina. This is going to be the dermatology portion of our 13-part series that's designed to help you master your didactic year and your boards. These are all of the diseases that are listed in the NCCPA blueprint for testable material. So that is what this PowerPoint will cover. Before we get into the diseases, let's lay some groundwork for dermatology. We have both primary and secondary lesions. Primary lesions are a direct response to the disease process, whereas secondary lesions have been modified in some way through either trauma, evolution, or infection. The way that you should expect to see these on your exam is they may give you a list of secondary lesions and then ask you to pull out the primary or vice versa. The types of lesions that are considered primary are macules, papules, patch, plaque, vesicle, bulla, nodule, tumor, wheal, pustule, and cyst. Our secondary lesions include scale, crust, erosion, fissure, ulcer, excoriation, lichenification, scar, atrophy, and maceration. If we look at the bottom part of this slide, this helps us to describe the patterns and the appearance of the lesions. So let's start with the lesion distribution. If it's a dermatomal pattern, it's along a nerve tract, something like shingles. Flexural is on the ventral surface. Extensor is on the dorsal surface. Perioral is around the mouth. Periungual is around the nail beds of the toenails and the fingernails. Symmetrical, we see a mirror image, something like plaque psoriasis. Intertriginous is the skin folds, which tend to be moist, and so you see more fungal infections in these areas. Palmoplantar is going to be the palms and the soles, something that we would see maybe on hand, foot, and mouth disease. The configurations help us to describe the lesion in general. So if it's ring-shaped, it could be annular. Gutate is drop-like. Stellate is star-like. Gyrate is coil. Verrucous is wart-like or thickened. Serpiginous is kind of S-shaped or snake-like in the border. Reticular or lacy is going to be a net-like rash. And then discoid or nummular is going to be round. So let's look at these in a little bit more specifics here. So let's start with our primary lesions. A macule and a patch, these are non-palpable, they're flat. They're discolored compared to the surrounding area, and they occur at the dermal epidermal junction. The difference is the size. A macule is smaller than 1 centimeter, and a patch is larger than 1 centimeter. Papules are palpable, they're raised. That's how you can remember the difference. So macules are flat, papules are palpable. These occur within the dermis. Papules are smaller than 5 centimeters. A confluence is an area of papules that's larger than 1 centimeter. And then a plaque is a broad sheet of papules, Vesicles and bullas, these are fluid-filled blisters and they're raised out of the skin. A vesicle is usually smaller than 5 millimeters and they occur in clusters, something like a herpes simplex. Bulla are larger than 5 millimeters, and these usually occur in a singular type of pattern. Pustules and cysts, these are fluid-filled sacs. So a pustule is filled with purulent fluid. It can be yellowish or white in coloration and raised. And you can see on that top picture there, that's a good example of a pustule. Cysts are enclosed sacs that are filled with a liquid material, a solid material, or a semi-solid material. And on that bottom picture here, this is called a mucus cyst, and it's filled with kind of gelatinous material from the joint. Wheals are a response to an allergic reaction. They can also be called urticaria or hives. You can see in this picture here that this person has drawn these letters and numbers and they become raised. This is an IgE-mediated allergic reaction, and so they get this transient raising in the skin that becomes itchy. And this is specifically called dermographism, where you can write a picture or a letter and it will appear above the skin. Tumors and nodules are deeper in the dermis than a papule would be, and they can be benign, non-cancerous, or malignant, cancerous. Nodules are smaller than 1 centimeter, and tumors are larger than 1 centimeter. Let's look at our secondary lesions. We have scale. You can see in that picture, it's kind of a white flaky crust. This is an accumulated excessive stratum corneum. In a crust, these are dried fluids, and they can either be yellowish in color, so serous drainage or purulent drainage, or red, hemorrhagic, which is blood. A fissure, an erosion, and an ulcer, these are all breaks within the skin. So you can have a narrow, deep crack, which is called a fissure. An erosion, remember E for E, erosion is only the epidermis. These tend to be kind of oozy or weepy. These do not cause a scar because they're shallow and superficial. Ulcers go from the epidermis into the subcutaneous tissue, and they will form a scar because they're deeper. Common types are chancroid, decubitus, and venous stasis. Lichenification and atrophy are opposite of each other. Lichenification is a thickening of the skin where you get these accentuated folds, kind of like elephant skin, usually as a result of chronic scratching. Atrophy is a thinning of the skin where the skin becomes very shiny, delicate, and wrinkled. And this can be in the response to a normal aging process, or this can be associated with chronic steroid usage. Scar and a keloid. A scar is a normal response to a trauma to the skin. So you have a destruction of the dermis, you get this pinkish kind of white discoloration, and it destroys the hair follicles in that area. The difference between the keloid and the scar is that the keloid grows beyond the original wound edges. You can see in this picture here, she had some kind of abdominal surgery, and she's developed this very hypertrophic scar that was beyond where the incision was for the surgery. So that's kind of our groundwork for dermatology. Let's move on to our viral conditions. And we're going to start with some diseases that used to be common childhood diseases that we don't see as commonly anymore because we have the vaccines for them. So let's start with measles, which is also called rubeola. The history for this one is the 4 Ds and the 3 Cs. It's a 4-day fever followed by 3 Cs: cough, coryza, which is nasal swelling, and conjunctivitis, which is redness of the eyes. Then that rash starts about 2 to 4 days after those first symptoms. The physical exam for this, let's look at these pictures real quick. The top picture is Koplik spots, which are very specific to measles. It's a bluish gray ulcer on an erythematous or red base that occurs in the oral mucosa. Then if we look at the bottom picture here, this is kind of that net-like fine morbilliform rash that goes over the entire body. Like I said, this used to be a disease of childhood, but because we have the MMR vaccine, we don't see it as commonly. So in the history, we need to be thinking about unvaccinated patients, foreign-born patients that didn't require vaccines, or possibly immunocompromised adults whose titers are low. This is a clinical diagnosis, but if we're unsure, we can do a rapid PCR genetic test from a blood sample, a nasopharyngeal swab, or a urine sample. We can also look at serum IgM titers, but these are only accurate on the 3rd day of the rash, or a viral culture, which can come from a nasal or a throat swab. You're going to see that the treatment for a lot of these diseases that we talk about here shortly have the same kind of algorithm. It's symptomatic treatment. This will self-resolve within about 10 days. Studies show that vitamin A can reduce the mortality in very severe cases of measles. We're going to treat their dehydration with fluids. Hopefully we can do PO, but if not, we can do IV. We treat their fever with acetaminophen or Tylenol, their rash with antihistamines like diphenhydramine, hydroxyzine, topical camphor or menthol. They have kind of a cooling effect, or we can do a short-term course of steroids if it's very severe. The complications that come secondary to measles include pneumonia, otitis media, encephalitis, and corneal ulceration. Now let's move on to German measles or rubella. This is very similar as far as the rash appearance to measles. They'll start with the flu-like symptoms, the conjunctivitis, but this one has a key difference is that the most common historical complaint is pain with eye movement. The rash is going to start about 1 to 5 days after those flu-like symptoms. This is again the mildly pruritic rash, just like you saw in measles, starts on the face, goes to the trunk and the limbs within 24 hours. So it's a faster spreading rash. It's also a faster resolving rash. By day 2, the facial rash is gone, and by day 3, the truncal rash is gone. They may also develop suboccipital or posterior cervical lymphadenopathy in large nodes at the back of the head or the back of the neck or the head. The Forchheimer sign occurs in about 20% of patients, and that's where they get these little pinpoint hemorrhages called petechiae on the soft palate. This is a highly contagious rubella virus. Again, it was a childhood disease. We don't commonly see it much anymore, but think about this in our unvaccinated patients. This is a clinical diagnosis, but you can also run an IgM titer if you're not sure. Like we said, this was a faster resolving rash. Instead of 10 days for measles, it gets better in 3 days. We treat our fever with acetaminophen, our dehydration with fluids, our rash with diphenhydramine, hydroxyzine, the topical camphor or menthol. But here's our key difference, and this is where your question on your exam is going to come from. They are teratogenic. German measles is teratogenic. So if a pregnant woman were to get this, their babies can have birth defects, most commonly hearing loss, retinopathy, cardiac defects, miscarriage, or stillbirth. And so the best way to not get this is to prevent this with the MMR vaccine. Erythema infectiosum and exanthema subidum, also called fifth disease and sixth disease. These are very common viral exanthems of childhood. In erythema infectiosum, they're going to get a 3-day low fever before the pruritic rash. In sixth disease, they're going to get a 3-day high spiking fever that can actually induce febrile seizures in about 15% of the patients. So remember, if erythema infectiosum is a lower fever, exanthema subidum is a higher fever. The big key difference here between the physical exam, and you can see in this little guy's picture here, they get this coalescence of red on the cheek in fifth disease. You take 5 fingers for fifth disease and slap yourself on the cheek. That's how you can remember the slap cheek rash is fifth disease, not sixth disease. They'll get this truncal lacy rash in both of these disorders. But in exanthema subidum or sixth disease, they get something called Nagayama spots, which is erythematous papules on the soft palate and the base of the uvula. So those are key differences in the physical exam for both of these. A commonly tested board question for fifth disease is what's the causative agent, and that's going to be parvovirus B19. Both of these affect childhood populations more commonly, but fifth disease can go all the way up to 15 years of age, whereas exanthema subidum, sixth disease, usually stops at age 3. Both of these are clinical diagnoses. You can order a serum IgM if you're not sure. These will self-resolve within a couple of weeks. We treat our fever with the acetaminophen, our dehydration with the fluids, our rash with the antihistamines, diphenhydramine, hydroxyzine, tropical camphor, or menthol. Pineriasis rosea is a very common dermatitis. This is an itchy, slowly developing rash, and about 5% of people will have malaise and flu-like symptoms prior to the onset of the rash. The physical exam findings are key on this disease here. I'm going to draw you to this picture here. There's a circle around the herald patch, and this is usually the first sign of the dermatitis. It heralds the onset of the rash. It's usually whitish and flaky in color with a distinct border. As this rash progresses, it goes in a Christmas tree type of pattern down the trunk. And the lesions are kind of a pinkish in coloration. They're not bright red, so we call them salmon colored, and they have got this flaky skin on the inside. So a flaky skin, salmon colored rash that goes in a Christmas tree pattern is Pineriasis rosea. It's idiopathic. We don't know what causes it. The original theory was that it was a herpes virus, but that's been disproven in subsequent studies. This is common. It's a clinical diagnosis. It's an annoying one for patients because it takes 6 to 8 months to get better. Topical treatments for this, if it's localized, you can use a zinc oxide, a calamine lotion, corticosteroids. We can also use oral medications like diphenhydramine, hydroxyzine to control the itch. We can do a short course of oral steroids if it's really severe and bothersome to the patient. UVB phototherapy has been shown to decrease the itchy is associated with this disorder. And then interestingly, acyclovir given within 1 week of the rash can actually shorten the duration. So that's an interesting thing that, it was proven that it was not a viral rash, but we can use acyclovir. Herpes simplex virus, we have type 1 and type 2. For simplicity's sake, we will say type 1 is going to be oral, type 2 is going to be genital. You can get type 1 in the genitals and type 2 on the oral, on the mouth, but for simplicity, we're going to leave it as type 1 is oral, type 2 is genital. In type 1, the history, for the first onset, they're going to feel bad, fever, pharyngitis, burning vesicles on their lips. And then in the subsequent or recurrent outbreaks, they're going to only have the vesicles. They won't have the systemic symptoms. On type 2, with their first outbreak, burning vesicles on the genitalia, dysuria, fever, and a history of unprotected recent sex. There's about a 4-day incubation period. So you want to look through that sexual history. Grouped vesicles on an erythematous base. That's important, and I'm going to repeat that. Grouped vesicles on an erythematous base. This is the descriptor of herpes simplex virus. If it's on the vermilion border, which is the outline of the lip there, we call that type 1. If it's on the genitals or the anus, we call it type 2. Herpes virus is what causes this, and it's dormant in cranial nerve 5, which is our trigeminal nerve. So that's type 1, and that's a very commonly tested exam question. Is cranial nerve 5 is where type 1 stays dormant, which makes sense because cranial nerve 5 has to do with this area, the sensation in this area of our face. 25% of the population has this, and your subsequent outbreaks are triggered by fever, stress, or sunlight exposure. The diagnostics for this are highly tested on your exam. So giant cells on a Tizank smear or a PCR, which is a genetic test for these. We're going to treat them with antivirals within 72 hours of the symptoms to shorten the durations and the symptoms. Acyclovir, valcyclovir, and you can put these on 2 dosing regimens. Number 1, you can do a suppressive type of therapy if they have very common outbreaks. Or number 2, you can put them on just per outbreak therapy. They take a bolus dose of the antiviral when they have the outbreak. Next, we're going to talk about varicella zoster virus, and this is responsible for both chickenpox and shingles. So let's talk about chickenpox first, and that's the top picture there. This is usually a childhood disease, whereas shingles is usually an older disease, 50 years and older. So in chickenpox, painful and pruritic lesions, sick contact within 2 weeks. This is a highly contagious disorder. Dew drop on the rose petal. So you have an erythematous base with a vesicle, clear vesicle on top. And this is the common descriptor for the physical exam for this. Lesions are in different stages. Some are erupting, some are resolving, some are rupturing, some are growing that bulla. It starts on the torso and spreads centripetally around the body. This is the varicella zoster virus. It's very highly contagious, so vesicular fluid and respiratory droplets. This is a childhood disease, usually, but it can also be in unvaccinated adults. VeriVax is the vaccination for chickenpox. Clinical diagnosis on this one, we want to treat this with an antiviral within the first 24 hours. You don't have to do that, but that is a treatment option. We can use our oral antihistamines, Benadryl, hydroxyzine. Sarna is an anti-itch lotion that you can buy over the counter. Oatmeal baths may also be soothing for this rash, and we can treat their fever with acetaminophen. Let's move on to shingles, which is the bottom picture here. This has a very specific physical exam finding. This one starts with fever, malaise, burning hyperesthesia. The skin is very, very hypersensitive in that area prior to the onset of the rash. And they have to have a history of chickenpox because this is the reactivation of the chickenpox virus. Unilateral, dermatomal, grouped crusting vesicular rash. Those words are all important in the descriptor there. Now, on your exam, they may either show you a picture or they may give you that descriptor, but that is a very specific description, a dermatomal type rash pattern for shingles. This is a reactivation of the varicella zoster virus, and this is a key point here too. This one is dormant in the dorsal root ganglion, not cranial nerve 5, like your herpes, but this one is the dorsal root ganglion, and you can get a reactivation of that as an adult. Normally, shingles is over age 50, immunocompromised patients, people that have not received the vaccines for shingles. Two of the marketed ones are Zostavax and Shingrix. This is a clinical diagnosis based on the pattern of that rash. We treat this with an antiviral within 24 hours, and that is very important on this one. IVIG is immunoglobulins that can be given to decrease the severity of this. Gabapentin is a medication that can reduce some of those hyperesthesia nerve pain type of symptoms. This one is not contagious, so you can't get shingles from somebody with shingles, but you can get chickenpox from somebody with shingles. So that's an important point there. Herpangina, or hand, foot, and mouth disease. Herpangina is a disease that only affects the mouth, whereas hand, foot, and mouth affects the hand, foot, and the mouth. Both of these will start off with a high fever, 100 to 104, sore throat, dysphagia, trouble swallowing, because look at that picture. I'm sure that that hurts that person to swallow. A non-pruritic rash, gray ulcerative vesicles with a red ring on the soft palate or tonsillar pillars. That's an important physical exam descriptor right there. That is herpangina. That's on the tonsillar pillars only. If it occurs on the mouth, as well as the hands and the feet, that's where we call it hand, foot, and mouth. A commonly tested exam question on this one is what's the etiology? And that's going to be Coxsackie A, spread by contact, very highly contagious, which is why you usually see this in kids, but you can also see it in the parents of the kids who have this. This is a clinical diagnosis and it self-resolves within about 1 week, but we can treat them symptomatically. Treat that fever with acetaminophen, treat the dehydration that they may get from the dysphagia with fluids. Molluscum contagiosum, also a very common one in children, especially children in daycare or elementary schools, because they're constantly touching each other. This one, if you look at the pictures here, you can see that it's a very specific appearance to these. So these are painless bumps. They're not itchy. They are waxy, smooth, domed papules with a central umbilication or dent in the center, and they are flesh colored, typically about 2 to 5 millimeters, and they can occur anywhere on the body. But it's very fair game for them to either show you a picture of this or give you that description, because that's very specific to molluscum. This is transmitted by a pox virus, which can either be spread through direct contact or fomite contact. So if I have this and I touch a doorknob and then you touch that doorknob, that's the fomite contact there. We talked about kids, daycare, sexually active adults can get this, immunocompromised people can get this, but much more commonly in kids. These self-resolve within about 6 to 12 months, so they take a while to get better. We can use cryotherapy, freeze them, curettage, cut them out. Cantharidin is also called beetle juice. This is a blistering agent that helps them to kind of dry up and fall off. Keratinolytics help to get rid of the top layers of skin. So this can be things like salicylic acid, anything really in that group to help kind of shed that top layer of skin and get rid of them. Veruca vulgaris, also called warts. There's 4 types that we'll talk about on this slide. We have veruca plana or plana, which is a flat type of wart. That's the top picture there. That can occur commonly on the hands, the knees, and the face. Filiform is the second picture down. It's kind of finger-like, and that's more common on the eyelids or on the lips. Veruca plantaris or plantar's warts occur on the bottom side of on the plantar side of the foot. So they're hard, they're painful. They're common in people who have poor footwear. They get these pressure points from continual walking on that area, and they get this thickened stratum corneum. Condylomata acuminata, that's the bottom picture there. That's genital warts. These are sexually transmitted. They're caused by HPV 6 and 11. They have this kind of cauliflower appearance where they're whitish in nature. They kind of look like they grow off of a stalk. If we stain them with acetic acid or vinegar, they will appear more white. We call that aceto-whitening. Physical exam, they are hyperkeratonic papules. They could have red or brown dots. If you look in that top picture there, you can see a good example of those red or brown dots that are the capillaries that have been raised up to the top of the skin. They may be tender or non-tender, depending on the type. Warts are spread through HPV or human papilloma virus. These are self-resolving. They can take a while. They may regrow even when they've gone away. Cryotherapy, we can freeze them. Salicylic acid is a type of keratolytic that can get rid of them. Curettage, you can cut them out. Silver nitrate, you can burn them. Laser therapy, and then podophylox. This is a treatment for only condylomata. So that's all of our viral conditions. Let's get to our bacterial and acne conditions here. Impetigo, there's 3 types that we'll talk about here, and they're all on the same slide because I want you to learn them together. All of them are pruritic, itchy, but some of them can also be mildly painful. Rarely do they cause systemic symptoms like malaise or fatigue. Let's start with non-bullous, and this is going to be our most common one. 70% of impetigo is going to be non-bullous, and that's the top picture over here. Multiple superficial circular lesions with a honey-colored crust, and that's an important point. Honey-colored crust, which is exactly what you can see in that picture. The nose and the mouth are going to be the most common, and this one does not affect the mucous membranes. This is much more common in younger children, so ages 2 to 5. Bullous is different because it does affect the mucosal membrane. So you get these very fragile bulla that have a yellow kind of cloudy fluid on the inside. They're most common on the face, the axilla, the trunk, perianal region, and the extremities, but again, they can occur within the mouth, the buccal mucous membranes. That's going to be more common in neonates and infants. Ecthyma, these are very deep, punched out leg ulcers that extend into the dermis, and they have a very thickened grayish yellow scab on top of them. And then they develop this ulceration that has a raised margin. This is going to be most common in the children and the elderly populations. Impetigo is highly contagious. It's spread by contact. Non-bullous and ecthyma, our main causative agent for that one is going to be Staph aureus, about 80% of the cases. Streptococcus pyogenes is implicated in the rest of the cases. In bullous, this is going to be a particularly virulent strain of Staph aureus that has this exfoliating exotoxin. That's why you get that sloughing off of the skin. Who gets this? It's very highly contagious. So contact sport athletes, healthcare workers, people that are in daycares, Those who have pre-existing skin conditions that cause an opening or a portal in the skin for that opportunistic bacteria to get in there. So scabies, varicella, eczema, insect bites. Hot or humid climates, it causes that overgrowth of bacteria, and then immunocompromised patients. This is a clinical diagnosis. If you suspect that this patient has MRSA, if they're very severely affected, you can do a culture and sensitivity of those lesions. If it's localized, we can treat this with an antibiotic ointment, so something like mupirocin. If it's secondary or it's severe, we can use an oral antibiotic, something like Keflex, which is cephalexin, Bactrim, clindamycin, doxycycline. We treat the actual lesions with wet to dry dressing, so it helps to pull that fluid out and help that lesion to heal. If they have widespread bullas, a mucosal bulla, then you want to treat them with fluids as well, because they're probably going to be dehydrated. Irrisibilis and cellulitis. Irrisibilis is a very superficial cellulitis, where cellulitis itself is a very deep, it affects more of the deep tissues. In the top picture there, that's a great example of irrisibilis. They get this painful rash, fever. Their rash, it's very important to note, it has very distinct margins. You can see exactly where that cellulitis is. It's bright red. They have edema, induration, which is thickening of the skin, and it's very shiny. It looks like an orange peel is how they describe that one. If it's severe, you can have lymphatic streaking. So you can get erythema going along the lymph channels. Most commonly, this is on the legs, 80% of cases, but 20% of cases can happen on the face, as you see here in this picture. Strep pyogenes is going to be the most common causative agent for irrisibilis, and this affects the upper dermis and the cutaneous lymphatic system. People who are more likely to get this have lymphatic obstruction. So if they have something like peripheral vessel disease. This is a clinical diagnosis, and we want to treat this with antibiotics because it's an infection. So penicillins or cephalosporins would be a good example of that one. Cellulitis, which is the bottom picture here, fever, malaise, very painful region. They may have an area where you have broken skin that was the opportunistic infection. That's where that came from. This type of cellulitis has indistinct margins. It's not a well-demarcated margin. They're hot, they're erythematous. They may have lymphatic streaking, which you can see very nicely in this bottom picture here. They may also have lymphadenopathy in the area that's affected. Staph aureus and strep pyogenes are going to be our causative agent for this one. And this one goes into the deeper dermis, which is whereas erysibilis is in that upper dermis. Who do we think about for this? IV drug users are a common population that we see with this because they're constantly causing breaks in their skin with injecting those IV drugs. Tinea pedis, or athlete's foot, can cause this kind of cracked skin in the feet that causes this good opening for an opportunistic infection as well. This is a clinical diagnosis. If they have systemic symptoms, you want to get a CBC. You'll see an elevated white blood cell count. And if they have an area that's draining, you want to get you can either take a culture from there or you'd get a blood culture. So in cellulitis itself, it does not always have an abscess. So you can't culture an area with an IND if it's just cellulitis. Antibiotics that we treat this with, examples would be things like cephalosporins, Bactrim, clindamycin, doxycycline. If we don't treat this, they may develop sepsis, which can be fatal. Abscesses. So abscess is a collection of purulent drainage or pus that can be associated with cellulitis, or you can just have an abscess in itself. We have a furuncle and a carbuncle. The top picture there is a furuncle. You can see that this encapsulated area of pus, it's usually in a singular hair follicle, but you may have an open pore where that's draining from. The bottom picture is an example of a carbuncle, which is coalescent furuncles with multiple areas of drainage. And the nape of the neck, at the back of the neck, is going to be the most common for that. These are very painful in nature and associated with people who chronically pick at their wounds. Abscesses are fluctuant. They're kind of bouncy. You can feel the pus underneath that. They're tender. They may have surrounding induration or thickening of the skin. The pore may have this purulent drainage like you can see in both of those pictures here. Your most likely causative agent for this is going to be Staph aureus. This is normal skin flora that gets an opportunistic infection. You develop secondary inflammation. This may come from infection or a foreign body that's embedded in there. You can develop this kind of walled area that causes this purulent drainage. Some people are also colonized with MRSA. Most commonly occurs in the nares. They may say, I have a painful pimple or a sore in my nose and I picked at it, and then they touch their skin. So they self-inoculated from that. Normally, we see abscesses in immunocompromised patients. We want to culture the drainage that we do when we do the incision and drainage. We want to culture that so that we can get a sensitivity so that we can more adequately treat that bacteria. The treatment of choice for this is incision and drainage. One of the more common mistakes that people make on the exam is they just treat it with oral antibiotics. This is an encapsulated area and it's not very penetrable to just oral antibiotics. So you want to open up the area with an incision and drainage, and then also treat them with an oral antibiotic. When we do the incision and drainage, you want to make sure that you make your incision long enough and large enough that it's going to allow for drainage. And some people may put in something called iodoform packing. It's got an antibiotic property as well as it acts like a wick so that that area can still drain and it doesn't become closed off again. Some of the more common antibiotics that we would use with an abscess would be things like Keflex, Bactrim. And then if they are a nasal carrier, we want to make sure that we're treating the causative reason for this. So we give them mupirocin in an ointment form to do nasal swabs a couple times a day for a couple weeks so that we can get rid of those nasal colonies of the MRSA. You can also use something called a chlorhexidine scrub, which is a surgical prep that you use to cleanse the bacteria off of the skin. Bacterial folliculitis. This is an inflammation or infection in the hair follicles. This is commonly associated with hot tub use. People who shave with a very dull razor causes little kind of microabrasions in the skin. This typically tends to be a mildly pruritic rash. And on physical exam, this is a great example of this. So red dots with white pustules that occur on the hair follicles. It spares the palms and the soles because we don't have hair follicles in those areas. Staph aureus is going to be our most common causative agent. However, most of the exam questions on bacterial folliculitis have to do with hot tub folliculitis. So the exam question may present to you as somebody was on a vacation and they were soaking in the hot tub and now they have a rash in the area that was covered by their swimsuit. The causative agent for that is going to be Pseudomonas, and that's a common exam question. We treat this if it's localized with an antibiotic ointment, things like mupirocin, neomycin, topical clindamycin, or erythromycin. If it's widespread, we can use an oral antibiotic like Keflex, minocycline, or dicloxacillin. Acne vulgaris. This is a common disease that presents right as people are becoming teenagers. This can be highly genetic. So you look for a family history of acne. Did it get worse with adolescence? And in women, did it get worse or does it get worse with their hormonal cycle, with their menses? When we look at the physical exam findings, I'm going to draw you down to this bottom picture here. We have whiteheads and we have blackheads. Whiteheads are closed comedones. So you see that purulent kind of collection underneath the skin. Blackheads are where the comedone is open. Sometimes these people, if they have chronic pickers, they may have scars on their skin. They may have very oily skin. Acne is much more common on the face, the neck, and the back. We have three different types: non-inflammatory, which would be in this picture here, pustular, or cystic. There's a multifactorial cause of acne. It's highly associated with androgens or testosterones, but it can be genetic or it can be due to hyperkeratosis. So here's where the kind of the pathophysiology comes in. The sebaceous follicle becomes blocked. You have Cutibacterium acnes that colonizes the area. You get an increase in sebum. It becomes inflamed, and then the follicle ruptures. And so that's kind of that whole pathophysiological process for acne. This is the most common in adolescents, teenagers. 15% of adults have this. It's associated with certain types of cosmetics. So if they're caking, foundation on their skin. Also associated with polycystic ovarian syndrome, pregnancy, and steroid use. The way we treat this, there's an algorithm for this. And there's so many agents that are prescription medication for this where you have combinations, but I'm going to try to kind of simplify this here. So a topical benzoyl peroxide or a retinoid, that's kind of our first line therapy. And if this controls everything, then we're okay. If not, our next line down is going to be a topical antibiotic. So anything that ends in mycin or a minocycline or a dapsone. Then we're going to add an oral antibiotic, which would be something that ends in cycline, like a tetracycline or a minocycline. If it's very, very severe, we can do an oral retinoid called Accutane. The key exam question on this one is that you must be on a contraceptive because Accutane causes horrible birth defects. So that's a good pharmacology exam question there. Other things that we can use is things like spironolactone. That's really good for cystic acne that occurs on the chin, or combination oral contraceptives for women only. It helps to balance out the hormones so that they don't get this menses related acne. Rosacea, you can see in these two pictures here, rosacea has a pretty specific physical appearance. With the history of this one, it's interesting because they get this kind of facial flushing that's worse with extreme temperature, so very hot, alcohol use, caffeine use, sun exposure, stress, or certain types of cosmetics they're very sensitive to. They also may complain of a kind of dryness or a gritty sensation in their eyes. The first picture, this top picture, I'm going to bring you over here. So erythema and papules or pustules along the cheeks, the nose, the forehead, and the scalp. They may also get this kind of red eyes from that gritty feeling. Telangiectasia, these are very superficial kind of blood vessels. They look like kind of spider veins. The difference between rosacea and acne is that rosacea causes this kind of dry, flaky skin, where acne is more of a greasy skin. The bottom picture here is called rhinophyma. This is when this condition has been untreated for years. They get this kind of enlarged nose. You can see the pores much more easily. Rosacea is idiopathic. We know that there's a genetic component. We know that it causes increased blood flow to the facial vasculature. We think that it could be related to dermal matrix degeneration, prolonged UV exposure, or overuse of topical steroids. But as of now, besides all these theories, it's technically considered idiopathic. This is much more common in Caucasian people, and the onset of this is about 30 to 60 years old. This is a clinical diagnosis. There's no testing that we need to do for this one. There's a lot of treatments for this. We want to use a daily sunscreen to decrease that UV exposure. You want to avoid any kind of drying chemicals, so over-the-counter astringents or toners. Antibiotics actually have an anti-inflammatory effect for this disease, and it reduces some of those small pimples. So topicals that we could use are things like metronidazole, erythromycin, clindamycin, and minocycline. We can also use topical alpha agonists, and this helps to reduce some of the erythema. Miravazo is a common one for that, or Rofade. Topical acne agents like benzoyl peroxide, azelaic acid, all of those can help with some of those pustule developments to help decrease those. And then oral antibiotics. Some of your cyclines can again help with this, with both anti-inflammatory properties and to help reduce some of those pustules. We can also use laser therapies for this, and laser therapies help to remodel that top dermal layer so that it reduces some of that blood flow. Now we're going to move on to our fungal, our papulosquamous, and our desquamation conditions. We're going to start with our Tineas, or our ringworms, also called dermatophytosis. So we're going to kind of separate them out into categories. So Tinea corporis is anywhere on the body that's not specified in the ones that we'll talk about below. This is an itchy type of lesion. Tinea capitis is on the head. It causes alopecia or broken hairs. It is itchy in nature. You can develop something called a carrion, which is a very painful, boggy lesion in the scalp. This is most commonly caused by Trichophytum tonsurans. Tinea pedis, or athlete's foot. This affects the feet and the toes, again, highly pruritic. Tinea cruris, or jock itch. These usually go together, Tinea pedis and Tinea cruris. And the way that I remember these is that athlete's foot and jock itch, they both have to do with people who play sports. They occur together. The important thing about Tinea cruris is it's only inguinal. It spares the scrotum and the penis. It's a very serpiginous kind of rash, so kind of an S shape. And again, this one is with Tinea pedis. Tinea manum occurs on the hands or the palms. It's very, very itchy. Tinea unguium, or onychomycosis. This affects the nails, and this one is non-pruritic. It's a fungal infection of the nails, most commonly caused by Trichophytum rubrum. This is more common over the age of 40, very, very common in the elderly population. How do we get this? This is highly contagious. So infected contact or an infected pet, locker rooms, barefoot in public showers, tanning beds, pools, shared towels, gym mats. What do these all have in common? They're very highly humid or have lots of moisture in them. And we know that areas that have higher moisture are more likely to grow fungal. So we know that this is a fungal in nature. Physical exam for this, it's asymmetrical. It is annular, it's circular. It has a red border with central clearing and a well-defined scaly border. And we'll see this on the next slide here. We talked about this as fungal in nature. So trichophytum, microsporum, epidermophytum in hot, humid areas, and it's spread by contact. More likely to get this are people who are athletes and diabetics. KOH prep is going to show hyphae. That's the diagnostic test for this is a KOH prep. Woods lamp is another useful tool. The microsporum canis will fluoresce green when you use that woods lamp. We treat these with topical antifungals. Some example of that would be like a miconazole, and a lot of these are over the counter. We can use oral antimycotics for Tinea capitis and onychomycosis only. The rest of them are going to be topicals. Examples of those would be fluconazole, itraconazole. You want to keep these areas dry. If we get rid of the moisture, we can help get rid of the fungus. You want to avoid steroids in these patients. Sometimes you're tempted to treat this with a steroid because it's itchy, but if you treat with steroids, that will actually immunocompromise that patient, and that will cause a kind of flush reaction where they'll get a worsening of this. Here are some of the pictures of what this looks like. So you can see Tinea corporis, that red border, you can see that scaly central area. Tinea capitis, you can see as alopecia in the area that's affected. Tinea minum, that's that very dry, flaky skin on the palms. Tinea pedis, you can see the cracked skin on that feet. Onychomycosis, this is affecting those toenails there. They're very ragged and yellow. And then Tinea cruris, you can see that this is in the inguinal region and it spares the scrotum and the penis. Tinea versicolor and seborrheic dermatitis. The reason they're on the same slide is because they have the same causative agent, which is Malassezia fervor. So let's start with Tinea versicolor. This is going to be a discolored area of the skin. The skin doesn't tan in there. Usually these people have hyperhidrosis. Again, those moisture-filled areas have the overgrowth of fungus. Surfers or the summertime because they're constantly sweating. Physical exam is important on this one, so I'm going to read it slowly. Multiple, oval, velvety, mildly itchy papules that are hypopigmented in light-skinned people and hyperpigmented in darker-skinned people. Most commonly occurs on the back, the trunk, the underarms, and the arms. Malassezia fervor is going to be the #1 causative agent for this. You can also have Malassezia clubosa and sympoidalis. Topical oils, moisturizers, and tanning oils can also cause this kind of overgrowth of that fungus. Humid climates, immunosuppression, topical steroids. KOH prep is going to be diagnostic for this. And this is described as a spaghetti and meatball type of patterns. You see these kind of circular areas and then the hyphae, so spaghetti and meatballs. The Woods lamp will also fluoresce orange for these. Treatment of choice for this is going to be a selenium sulfide shampoo because it covers a very large area and it's relatively inexpensive. So Selsun Blue is one that you can get over the counter. There's also a ketoconazole shampoo, Nizoral. Topical antimycotics example would be terbinafine. Oral fluconazole once monthly if it's recurrent. So if you're a surfer or somebody that's constantly getting this, you can use an oral fluconazole. Let's move over now to seborrheic dermatitis, also called cradle cap in that bottom picture, or dandruff. This is chronic flaking that's unresponsive to moisturizers. A lot of people think that it's just really dry skin, but it's not. Physical exam for this is also very important, so I'm going to read that one slowly. Greasy, yellow-gray scales with an erythematous base, most commonly on the scalp, the eyebrows, the nasolabial fold, the glabella, the chest, and then the ears. Scaly yellow-red pimples along the hairline and in the ear canal. Again, Malassezia fervor, most common causative agent, but you can also have globosa. In these patients, they will also have this pathophysiology where they get sebum overproduction and they have decreased T cells. This is a clinical diagnosis for this. You can do a KOH prep, but it's a very clinical diagnosis. Treatment for this, if it's cradle cap, you're going to use olive oil and very gentle scrubs to kind of exfoliate that off the baby's head. For people with seborrheic dermatitis, you're going to use a shampoo. So you can use that selenium sulfide or the coal tar. You can use a topical ketoconazole in this area. You can use topical immunosuppressants. They have an anti-inflammatory effect like tacrolimus. Short-term topical steroids can be helpful for if it's very itchy, but again, you don't really want to treat these chronically with steroids. Candidiasis. These are two in the pictures here examples of candidiasis. That top picture is an example of thrush, and the bottom picture is an example of fungal diaper rash. So we'll talk about 4 different types here. Diaper rash or intertriginous. That's the skin fold type of rash. This can happen with urinary incontinence. Obviously, that's something that happens in kids, but you can also have adults with urinary incontinence. Hyperhidrosis, very sweaty. They get these bright red papules like you can see in this picture. This is a very important point that I'm going to make here. Candidiasis occurs within the skin folds, whereas contact dermatitis spares the folds. And let me explain why. Remember that the skin folds are very moist areas, so it makes sense that you would have a fungal infection in that area. If it's a contact dermatitis, so let's say that they have an allergy to the type of diaper that they're wearing, that will spare the skin folds because it's only touching. The skin folds don't touch the actual diaper there. So if it's in the skin folds, it's fungal. If it's not in the skin folds, it's a contact dermatitis. Vulvovaginal, they get this kind of cottage cheese white vaginal discharge, very beefy red vulva. It's very painful. It's very pruritic, highly associated with antibiotic use because that clears out the normal vaginal flora and they get this overgrowth of Candida. Thrush is that top picture there. Most commonly in formula-fed infants, but it can also be in immunocompromised adults or people who use inhaled steroids for things like asthma. It's a white coating on the tongue that can be scraped off. Angular cheilitis or colitis, this is on the corner of the mouth. This is a painful red type of lesion, and that's where fluid collects. So if somebody has a trouble controlling their secretions and they're drooling a lot, they may get this. This is an opportunistic Candida albicans. So an overgrowth of the normal flora that you have. Obese adults, because they have more intertriginous areas. Infants for the diaper rash and the thrush, and then diabetics. Diabetics have chronically high elevated levels of glucose, and Candida loves glucose. So that's where you see that. That's also something if you have a patient that presents with multiple vulvovaginal type of candidiasis, you want to test that patient for diabetes. Diagnostic for this is going to be a KOH prep, and you may see a budding yeast on this. Treatment for this is going to be for the intertriginous areas. We can use an over-the-counter ketoconazole cream that will help with the itching. For vulvovaginal or angular cheilitis, we use an oral fluconazole and a topical azole. And then thrush, you're going to use oral nystatin. And if it's a baby, you have to put that on a Q-tip and kind of swab it on the tongue. You don't want them to drink it. And if you put it on the pacifier, that usually doesn't break it up enough to help it penetrate. So you really need to get a little cotton swab in there. You want to keep these areas dry to prevent this from coming back and then avoid steroids. Lichen planus. This is the 4 Ps of lichen planus. This is a pruritic lesion that erupts over about 1 week and it continues to spread for about 16 weeks. So the 4 Ps of this one: purple, polygonal, planar, plaques. And this is usually on our flexor surfaces. It can also affect the palms, the soles, the scalp, the genitalia, and the buccal mucosa. You get these white lines called Wickham striae, and that is very specific to this disease. So that's a good exam question there. The lesions are about 1 centimeter and can be either in clusters or individuals. You may also develop fingernail ridging. This is an autoimmune T-cell mediated apoptosis of epithelial cells. So all of your epithelial cells are dying off. And there are some known triggers that we are aware of for this. Beta blockers, medications for blood pressure, anti-malarial medications, diuretics, metformin for diabetes, metal dental fillings, graft versus host disease, and hepatitis C are all known triggers for lichen planus. We diagnose this if we're not sure with a punch biopsy. This can take a while to self-resolve, 6 to 18 months. We can use some topical corticosteroids, things like betamethasone. We can use some topical retinoids as well. Oral metronidazole is also used for its anti-inflammatory properties. Plaque psoriasis. We talked about this when we were kind of talking about a symmetrical type of lesion. In plaque psoriasis, the history is pruritic, painful, recurrent plaques that are worse in the winter because everything's more dry and improve in the summer because everything's a little bit more moist and there's more UV light. These are highly responsive to UV light. About 15% of people who have plaque psoriasis will develop psoriatic arthritis, which causes arthralgias or joint pain. So the physical exam for these: symmetrical, raised, irregular, or oval. If it's guttate psoriasis, it may be circular or drop-like. Well-defined plaques that are dark red with dry silvery scales. Dry silvery scales is plaque all day, all night. Make sure you answer that one correctly. These are most commonly on the extensor surfaces of the elbows, the knees, the scalp, and the trunk. They may also develop pitting in their fingernails. And the auspit sign, this is if you scrape that plaque, it will start to bleed. That's very specific to psoriasis. There's several components of this. It's autoimmune, it can be genetic, it is a T cell mediated inflammatory hyperproliferation. You can also have this in areas of trauma called the Kebner phenomenon. Things that we know can put people at higher risk for this: HIV, alcoholism, smoking, frequent sunburns, beta blockers, antimalarials, and anti-inflammatories. These can worsen the symptoms of psoriasis. So people who have this should avoid those medications. If somebody with guttate psoriasis gets a streptococcal infection, so a pharyngitis, they can cause a severe flare of their symptoms. This is a clinical diagnosis. You can get a punch biopsy if you're unsure. We have lots of things that we use to treat psoriasis. So you can start, if it's mild, with a topical steroid, triamcinolone, betamethasone, halobetazole. You can use a topical vitamin D analog, so calcitrol. Keratinolytics, so we can use a coal tar shampoo or anthralin. DMARDs, disease-modifying anti-rheumatic drugs, things like methotrexate. And then biologics. There's a ton of biologics, and they are highly commercialized, so you see them a lot on commercials, but Remicade, Humira, Enbrel, Stelara, there's tons of these medications. And the nice things about these is that they are used specifically to treat psoriasis, and they are very effective, but they can be very expensive, and they're not always covered by insurance. We'll talk about drug eruptions. So in the question for a drug eruption, they have to tell you that there is something that the patient took. So a recent new medication, look for that in the history of the question. They may develop a pruritic rash. If it's anaphylaxis, like you see in the top picture here, they may experience angioedema, swelling of the lips, facial edema, airway constrictions, shock, or hypotension. We have 4 types of drug eruptions. Type 1 is going to be IgE dependent. This includes urticaria, angioedema, and anaphylaxis. Insulin would be one of the more common in that group. Type 2 is a cytotoxic reaction. Excuse me. Hemolysis and purpura, penicillins, cephalosporins, sulfonamides, and rifampin. 3 is going to be an immune complex, vasculitis and urticaria, quinines for malaria, aspirin, antipsychotic medications, and sulfonamide. Type 4 is the most common, so you may get asked an exam question on that. This is a delayed cell-mediated hypersensitivity, contact dermatitis, exanthems, photoallergic reactions. The most common medications for this one are going to be topical neomycins, anticonvulsant medications, NSAIDs, ciprofloxacin, clarithromycin, doxycycline, fluconazole, tetracycline, and sulfonamides. Treatment for this is stop the offending agent, stop the drug. Oral antihistamines can help with the rash, so diphenhydramine, hydroxyzine. Topical steroids can be used if it's very mild, IM or oral steroids if it's severe. If they have angioedema, you want to give them epinephrine, and you want to give them 2 pens, because it's not for one for home, one in your car. It's that people who get angioedema get a rebound reaction that can be very severe. So if they have an anaphylactic reaction, you must transport them to the hospital for monitoring. All right, we're going to talk about desquamation reactions here. These are pretty much the same disease, they're just on a spectrum. So erythema multiforme, Stevens-Johnson syndrome, and then toxic epidermal necrolysis. All of these diseases have a prodrome of fever, malaise, pharyngitis, conjunctivitis, and pruritus. But the physical exam findings are going to be our difference. So erythema multiforme is associated with a cyanotic iris halo lesion, and this most commonly occurs on the hands, the feet, and the mouth. Stevens-Johnson is when you get bulla on less than 10% of the body surface area, and they most commonly occur on the hands, the feet, the mouth, and the trunk. If you have 10 to 30%, that's called SJS-10 syndrome. Then toxic epidermal necrolysis. This is the worst one. This is over 30% of the body surface area is covered with bulla. You get a separation of the epidermis and the mucosal membrane. So the eyes, the mouth, and the genitalia are affected. Large blisters, and the epidermis starts to slough off in sheets. There's a 50% mortality to toxic epidermal necrolysis. This is a type 4 hypersensitivity. We just talked about those drug hypersensitivities, most commonly with allopurinol, anticonvulsants, anti-inflammatory medications, sulfonamides, tetracycline, and vancomycin. This can also present in the presence of cancer, or certain types of infections can cause these. If it's a drug-induced, stop that drug. Treat them with antihistamines to help to alleviate the itching, analgesics if it's painful, an anesthetic mouthwash. If they're having bulla in the mouth, you want to protect that mouth. Steroids, wound care. SJS and 10 should be treated like burn patients because they're losing that epidermis. So they're going to get immunoglobulins. Their wounds are going to be treated as burns would be. You want to replace their fluids, and then you want to treat them with prophylactic antibiotics. These are some pictures of those desquamation reactions here, and you can see those iris lesions on the erythema multiforme. He's got these bullous mucosal lesions in Steven Johnson, and then the epidermis is sloughing off in that toxic epidermal necrolysis. That finishes up our first part of our dermatology. Hopefully this was helpful for you. If you are interested in learning more and seeing the rest of the completion of this unit, there's two options. You can either buy the full PDF, and that'll include the part 2 of the review video. If you want to learn a little bit more and really practice for your test, I offer clinical pearls, which are matching exercises, and a 50-question practice test that you'll get answer explanations so that you don't make the same mistakes on your actual test. I just want to show you real quick an example of our clinical pearls matching exercises. You'll get the most commonly tested parts of that question, and you can use a drop-down menu to select those questions. And this helps you to try to pick out the things that are most important on the questions. This is an example of our didactic level practice test. It would be 50 questions. It's designed to be the level of the didactic here. So it's a moderate level difficulty. It's less challenging than the board questions. I think it's more efficient to kind of build on what you know. So we start at kind of a moderate level. There's 4 answer choices for these. You'll also get the explanations for anything that you may have missed. And this one can be taken once. If you've already finished PA school and you're either taking the PANCE or the PANRE, we also have a more difficult level. These are 50 questions as well. They're designed to test the board level knowledge. So they have 5 answer choices, and they're designed to be a much more complex question. So I want to thank you for watching this video. Again, if you feel like you would benefit from watching the rest of this, please purchase this, and the links to this are provided at the end of the video. Again, please do not use this as medical advice. This is for educational purposes only. We are completely free of any pharmaceutical, commercial types of interests, and all of our photos have been appropriately attributed to their sources. So thank you all for watching, and I hope that this helped.